So good evening, colleagues. Welcome to this weekend's tutorial. And we're going to continue where we stopped last week. Last week we started airway management in critically ill patients in ICU. So today we're going to continue from where we stopped. Just a little bit of information for all Canexa training centers. Please, the Secretariat has asked that you please just identify yourself, write your name against your device so that it can be recorded for tracking purposes. So please do comply. I don't know if writing in the chats will help, but at least if you write your name, all right, and just identify yourself, then it can be followed up. That is from the registrar, Dr. Mashava. Okay, thank you. All right, so we talked about how important airway management is in the critically ill, and we did talk about the uniqueness of the airway of the critically ill, so that we do not waste too much time. Let's just go to the second. We did talk about endotracheal intubation in the critically ill. Maybe I should just go back a little and just refresh our memories. All right, we did talk about the airway management in the critically ill, and we started with endotracheal intubation in the ICU, and we looked at the different indications. All right, pulmonary gas exchange, protection of the airway, cardiopulmonary resuscitation following cardiac arrest, post-surgical procedures, and to maintain a patent airway, especially following severe trauma. All right, Irene Isonu, you're raising your hand. You want to say something?
Sorry, I raised it in error. It's a mistake. I'm trying to bring it down. Sorry, I raised it in error.
All right. So we looked at the airway management, the stepwise approach, and we talked about assessments, which is crucial. And we looked at the Makocha score last week. All right. And we talked about the equipment for endotracheal intubation, and where I told you that less is bad. So the more the equipment, the better. Okay. And we looked at the plan A. The plan A is to prepare, oxygenate, and intubate. All right, and if that fails, there are other things which did say that airway management critically ill should follow the rapid sequence induction, all right, and intubation. All right, this is to prevent aspiration with suspended full stomach. Most of our patients in ICU are regarded as full stomach patients, and we talked about proper drug selection in terms of induction agent, either with ketamine, propofol, or with co-induction. And we talked about the advantages and disadvantages of using succinylcholine as relates to rocuronium. And we did say that you must always have a vasopressor ready. The multipeller, the multipeller algorithm. All right, we looked at it last week, and so that we don't waste time, I'm just going over it. All right, and we talked about airway red flags. All right, and we talked about prolonged intubation and the complications, and we looked at the smart strategies of preventing or managing prolonged endotracheal intubation in the ICU, and we looked at the GHOST criteria for planning to extubate, extubation readiness, all right, in the ICU. So today, let's just go to what we have. Today, we're going to be looking at the second way of airway management in the ICU, and that is tracheostomy. Okay, I have a case scenario here. Just think about it when we come back. Maybe we'll talk a little more about it. So the case is a 55-year-old male patient, non-hypertensive and diabetic with chronic obstructive pulmonary disease. who has been admitted to the ICU due to community-acquired pneumonia leading to acute respiratory failure. Patient has been on ventilator for some days with minimal improvement, and his current ventilatory settings are still very high, and prolonged intubation is anticipated. So how do you manage this patient? So we'll discuss the management plan at the end, but just have it at the back of your mind, this case scenario. All right, less about 20% of all patients admitted to ICU somehow we need a tracheostomy. All right, and this is from a study that was published as far back as 10 years ago. I'm sure maybe the statistics would have changed a little, but at least 1/4 of our patients, all right, in ICU from anecdotal in observation require some form of tracheostomy, all right, for different reasons. And it is not without these complications. About half of these patients have complications related to tracheostomy, and most of the times this occur either during the procedure. Some of us must have experienced some form of cardiac arrest or desaturation, significant desaturation during the procedure, but most of them also occur after the procedure has been done with tube displacement, with few episodes of airway obstruction and hemorrhage. All right, so we looked at the indications and the advantages of tracheostomy. All right, one of the commonest indications for tracheostomy in the ICU is prolonged endotracheal intubation or failure to wean from the ventilator. All right, so prolonged ventilation or prolonged endotracheal intubation is when intubation or ventilation is expected or is taking longer 7 days. All right, and this patient, you expect a good recovery, so you want to offer them tracheostomy. All right, one of the advantages of tracheostomy is that there's reduced requirement for sedation. Don't forget that most of the times, like my practice, I don't like, I often tell, my people that for patients who do not require, especially traumatic brain injury patient or neurosurgical patient, want to keep our Richmond agitation score, sedation score, maybe around maximum -1, -2. And tracheostomy helps to facilitate that because it's better tolerated by the patients and there's reduced requirement for sedation. And this also helps to facilitate early weaning from the ventilator. All right, patients with airway obstruction, especially including vocal cord paralysis, will benefit from tracheostomy. Patients with neurological diseases like Guillain-Barré syndrome and other patients with traumatic brain injury with prolonged recovery period will require airway protection, and the tracheostomy is better. Effective pulmonary toileting, all right? So tracheostomy offers a better airway toileting and recruitment maneuvers, and it's also better to clear secretions. So these are some of the indications and advantages of tracheostomy, but the commonest of them is prolonged endotracheal intubation, whether it is anticipated or incidental. All right, and so tracheostomy is offered for such patients. All right, so we can have surgical tracheostomy or what we call open tracheostomy or percutaneous tracheostomy. All right, a meta-analysis that put data from 5 studies which involved about 236 patients showed that percutaneous tracheostomy was associated with shorter operative time, less perioperative bleeding, and lower incidences of postoperative infection compared to the open tracheostomy. Although the study found out that there was no difference, statistical difference in overall operative complication or mortality, all right, comparing the two types. But percutaneous tracheostomy, where we have the expertise and the equipment, is usually less to perform. Takes less time to perform, can be performed at the bedside. You do not require to book the operating room and before you do it. It's less expensive, all right, and complications have been found to be less frequent. So if you have a choice, you want to go for percutaneous tracheostomy for your patients requiring surgical airway. All right, so a lot of discussions have been on in the literature, all right, with different definitions as regards to what is early or late tracheostomy. All right, oftentimes early tracheostomy has been advocated, all right, and it's been found to enhance patient comfort, like I mentioned, decrease the need for sedation and potentially, decrease ICU or ventilator days. All right, so but there are different definitions, and it remains to be seen what different centers, adopt as protocol. All right, so by definition, classically, tracheostomy, early tracheostomy, should be done, within 5 to 7 days of endotracheal intubation. But sometimes, your clinical judgment comes to play, especially with the advent of low pressure cuffs of your endotracheal tubes. All right, so patients tend to tolerate longer period of low pressure endotracheal tubes in situ. Right, this may allow time, for tracheostomy to be extended, especially if you project likelihood of extubation. And sometimes, even when we have rigid rules, this patient needs to be tracheostomized within 7 to 14 days. But if you feel that this patient, the likelihood of extubation is higher, you may want to allow them a little longer, maybe to 10 or 14 days. But it all, boil down to clinical scenarios and the clinical judgment of the attending physician. All right, the Eastern Association of Surgical Trauma actually advocates lesser days, 3 to 7 days, all right, for patients with closed head injuries or in those who require prolonged ventilative support. And this is where your clinical judgment comes in. If you feel that this patient will require longer days of intubation, some persons have felt it's better to start, to do early tracheostomy. All right, some studies have also shown, Korat and colleagues show that tracheostomy placement not more than 7 days after initiation of ventilatory support actually lower the rates of ventilator-associated pneumonia and reduces the length of stay on the ventilator. So all of this, we synthesize them and we just say that, okay, early tracheostomy should be done between 7 days of intubation. Anything above 7 days before you give tracheostomy, it falls under the definition of late tracheostomy. All right, and some of the post-tracheostomy care is important. And like we mentioned, about 50% of complications of tracheostomy resulted from poor post-tracheostomy care. All right, so we're going to just go over this. So after tracheostomy, ensure that the cuff pressure of your tracheostomy tube is in the range between 20 to 25 millimeters. All right, ensure that just like in the tracheal tube, ensure adequate humidification. All right, which can either be active or passive. All right, this is to prevent thick and dry secretions. All right, which can actually cause airway obstruction. Always ensure the head of the bed is elevated. All right, this is to minimize or reduce the risk of aspiration. And oral feeding should be evaluated by a speech, therapist. In the first 24 hours, it's very crucial that the tracheal lumen is suctioned every hour. All right, this is because of bleeding and secretions, which is more rampant during that first 24 hours after the procedure. Now, after the first 24 hours, you can extend this for every 4 hourly. All right, so taking care of tracheostomy can be more intensive. All right, so ensure that for the first 24 hours, the tracheostomy tube, the lumen should be suctioned every hour, and after 5 to 7 days, you want to do 4 hourly, and the first tracheostomy tube change should actually occur within the first 5 to 7 days after the insertion of tracheostomy. Or after 5 to 7 days, 1 week of tracheostomy, you want to remove your skin sutures. All right, this will also allow the stomach to heal, all right, and granulating tissues to heal. It helps, during the cannulation. And always ensure the availability of smaller size tracheostomy tubes and endotracheal tubes. Actually, for every tracheostomized patient, we should have your equipment ready. All right, so after 5 days, change the first tube. All right, please can we mute ourselves, please? Mute yourself upon entry, please. Please mute yourself, please. All right, thank you. Okay, so always ensure you have different sizes of tubes, all right, and every time you're changing the tube, you clean your tracheostomy tube and you put a new one, especially after the first 5 days. Okay. All right, so there are complications of tracheostomy. All right, one of them is the stenosis, tracheostomy stenosis, and this can be avoided by keeping the cuff pressure around 20 to 25, like we mentioned. So we can have fistula formation, we can have tracheomalacia with the collapse of the tracheal rings. You can have tracheal ring rupture, infection actually can happen. All right, hemorrhage, hoarseness of voice, surgical emphysema with forced tract, infection of the stomach, and pneumonia can actually happen, especially aspiration pneumonia. All right, pneumothorax, forced placement of cannula, and this patient can actually have cardiac arrest. So, as good as tracheostomy is, it is not without its complications. All right, so tracheostomy does not end with just a patent airway. Decisions must be taken as to when to decannulate. I don't know what happens in your center. Different centers have different decannulation protocols. I'm aware that some persons feel that it's the duty of the ENT surgeons who place tracheostomy to decannulate. But no matter what it is, every intensivist, every clinician working in ICU should be versed about the cannulation. A lot of times waiting for somebody to come from outside can prolong the duration. So we need to understand the need. Decannulation is the process involving the removal of your tracheostomy tube from the patient and allowing the patient to begin to breathe through their normal airway. All right, so indications for decannulation, you want to assess for respiratory stability, and we're going to go into that more as we go on. You want to ensure that the patient can maintain a clear and patent airway, and you want to do a swallow test as we continue. We'll see more of that as we go on. All right, so this is important. I think I should just go to this flow chart here. All right, so when you have decided to decannulate your patient, all right, the first thing to do is assessment. You want to do assessment, and it's a comprehensive assessment, so to say. All right, you want to ensure that your saturation is above 92%, while the patient is breathing room air. Patient has effective cough, all right, and the patient is able to manage his secretions. There should be absence of infections, and if you need to obtain an X-ray to ensure that there are no significant airway abnormalities on your chest X-ray. At least there should be partial swallowing effectiveness to reduce the risk of aspiration, and you want to ensure that the absence of obstruction of the upper airway. All right, so the first assessment should be comprehensive. Patients should have the adequate GCS, patients should be alert and oriented. All right, so the basic principle is that before you start the cannulation, be ready to recannulate. All right, be ready to recannulate. And this is why we do not usually suture the stomach, so that in case the patient goes into any form of respiratory distress or airway obstructions, you can actually just open the stomach and allow the patient to breathe. All right, the best time to decannulate should be in the morning. All right, where you have all the necessary assistants and everybody. It's a good practice to start the cannulation in the morning, and you want to cover the stomach with some permeable dressing. All right, this also helps, some air and all that, even when you have removed your tube. Close monitoring is important. We know that ICU should be 1-to-1, so a patient undergoing decannulation should be adequately monitored. All right, so if your assessment, you're happy that your patient is ready for decannulation, you want to do what we call capping trial. All right, and this is when you put a cap on the tracheostomy tube. All right, what happens is that you're trying to encourage the patient to breathe through their normal airway. All right, after cough test. So you want to do a cough test, deflate the cough, put a cap over the tracheostomy tube, and the patient will be forced to breathe through his or her normal airway. But note that capping should be done by authorized personnel. All right. So if the patient passes your capping, capping should actually be gradual. The first, I like to go gradual, the first 2-3 hours. Then, if the patient passes capping for 24 hours, then you can proceed to full decannulation, or what we call trial of decannulation. And you observe this patient for 24 hours before discharge. Now, if the patient was only capped for 12 hours and there are concerns, you go back, you remove your cap, and allow the patient to breathe through the tracheostomy tube. But if it fails after these 12 hours, you want to assess the airway either with your chest x-ray or your bronchoscope to ensure that there are no abnormalities in the airway making capping to fail. Okay, so there are challenges of decannulation. All right, one of them is the risk of respiratory distress or failure after tube removal. The normal practice, the good practice is to have your tracheostomy trail, all right, by the patient. So after decannulation, at least for the next 24 hours, the tube should still be there in case there's respiratory distress or failure. You just put the tube back in there. So there's a potential for airway obstruction, which could be due to swelling, all right, or mucosa plugging, either from your secretions. All right, patients could have impaired swallowing function, and this could lead to aspiration of gastric contents or secretions. So always ensure that the patient passes your swallow test. Please, can we mute ourselves? This thing is being recorded. Please, upon entry, please mute yourself, okay? All right. One of the things I found out about, problems with the cannulation, challenges with the cannulation is psychological. All right. I had a patient recently that we're trying to decannulate. The patient had so much anxiety and fear, and it's important that we take this into account. We need to counsel and follow up with our patients. Explanation of procedure is very important. So psychological factors is very important. All right. Re-interventional needs. There's need to inside the tracheostomy tube if it's not successful. So whoever is decannulating must be fast, must be able to pass the tracheostomy tube back into the stomach if there's a failure of decannulation. All right. So that is about tracheostomy. And if we look at what we did before, we should be able to answer our question, based on what we have. So let's just quickly discuss this briefly. All right. Maybe this tutorial will take a different approach. We'll discuss each clinical scenario after we discuss each case. So is there anybody here who wants to attempt this clinical scenario? A 55-year-old male patient, non-hypertensive diabetic, all right, it's been on mechanical ventilation for 5 to 7 days with minimal improvement, still requiring high ventilatory settings. So how will you manage? What will be your airway management plan? Yes, so let's quickly discuss this as we move on in this discussion. Just unmute yourself, and just you don't need to be recognized. Just unmute yourself and start discussing this case. Anyone? Is anybody attempting this? Can you hear me?
Yes, we can hear you, sir.
Yes, sir. Yes, sir.
Yeah, so who is attempting? Ichabod, you want to attempt?
Okay, I can give it.
Afosina is there.
I
Please
can
go
give it a
ahead. Go
shot.
ahead. Take a shot.
Okay. So based on the history, this patient has anticipated prolonged intubation, and based on the clinical features that he isn't even improving on the current tertiary support. So I would opt for an airway tracheostomy, which can be done on either day 3 or day 7. So it will be a surgical tracheostomy, which has to be done in theater. And upon insertion of the tracheostomy, I have to elevate the bed to at least 45 degrees and ensure that there is optimal good cuff pressure, probably about 20 to 25 millimeters of mercury, and check if how the patient is doing on the tracheostomy in ICU, and ensure that we do the tracheal suctioning every hour during the first day of tracheostomy, then change to 4-hour suctioning. I would remove the sutures at day
Day 5. Is Dr. Ichabod still there? We can't
Yes,
hear
I'm
you.
still here. Oh, probably maybe network issue.
Network, yeah.
Yeah, I was saying that I would opt for an airway tracheostomy, either on day 3 or day 7.
Okay.
Yeah, so upon doing an airway tracheostomy, after inserting the tracheostomy, I would elevate the bed to 45 degrees and sanction every hour. And then next day I would start sanctioning every 4 hours to just for the tracheostomy care, and also ensure that the sutures are removed at day 7. And also the patient should have optimal cuff pressure for the tracheostomy tube,
Beautiful.
tracheostomy cuff.
Yes, beautiful. Will you want to take these patients to theater? Will you want to do a surgical? You know, there's a discussion on bedside and bedside tracheostomy, or you take the patient to the OR. What are the advantages and challenges, with each of your decisions? Are you a bedside tracheostomy patient, or the patient must go to OR?
Based on my personal experience, I wouldn't opt for a bedside tracheostomy. I would opt to take the patient in theater and do it in theater, unlike doing a bedside tracheostomy.
Okay. Do we agree? How many of you would like to do a bedside tracheostomy here?
Chief, I think I would like to do a bedside tracheostomy.
Okay, that's Dr. Rie.
Preferably, I'll prefer to do the Seldinger technique, and the reason I want to do that is because it's been shown that even with aesthetics, its recovery is faster, and with Seldinger technique, you tend to just shear the muscle rather than cut through them.
Yeah. John Claude, you have something else to say?
So probably for this patient,
Yes,
as
hello?
we see hypertension and diabetes with COPD, and on ventilator wise, he's requiring high ventilator setting.
Yes.
So disconnecting a patient and possible transfer to the OR will be difficult. So I would prefer for bedside tracheostomy.
Great, great. Yes, each of the decisions, you can, argue for or argue against, but the best thing, if you're going to do bedside tracheostomy, is to opt for percutaneous tracheostomy. And where there are no facilities or equipment for percutaneous tracheostomy, I've also quite encouraged our ENT surgeons to do bedside tracheostomy, and we have anesthetists, we can, control the environment. But one of the problems they have is because of the bed, which is not treatable, and sometimes, the risk of infection, especially because of the presence of other patient. But if you look at where the pros and the cons, I would want to do a percutaneous tracheostomy if it's available, or if not, a bedside tracheostomy will still be better, like what Dr. Rie said, disconnecting the patient from ventilator transport. And don't forget that transport of the critically ill is is an area that requires some degree of expertise and all that. So great. So this patient ends an early tracheostomy preemptively. We are not going to wait till 7 or 10 days. Or is there anybody that wants to wait for 10 days or, for late tracheostomy? I don't think so. Everybody agrees that from the patient's clinical presentation, minimal improvement after 5 to 7 days on high settings of ventilator, patients with COPD, hypertensive, diabetic, I think it should be preemptive and offer this patient early tracheostomy. All right. So great discussions, colleague. Let's go to our next.
I have a question.
You have a question? Please go ahead.
Yes, please. So, you said that after 5 to 7 days, we remove the
Dr. Rie?
Yes, sir.
The Dr. Rie that spoke before was a man.
Not the one that spoke earlier.
Okay.
So I want to ask a question. By day 5, we remove the first systemic, and we also remove the sutures. So if we're changing that tube, are we going to still secure that second tracheotomy
Hey,
tube?
my God, your network, we can't hear you.
Oh, okay. I'll type my question.
I think you are using two devices. That is likely.
Okay, Dr. Rie, if I hear you well. Okay, were you saying that if you after 5 days, what is the question about 5 days? All right, maybe at the end we can take that question. Let's just move on because I didn't quite get the question and the contribution. All right, so let's go to the next discussion. Okay, so this is another case scenario. Angelique Abimana is a 45-year-old female with history of asthma, recent upper respiratory infection. She was brought to the emergency department in severe respiratory distress following an acute asthma exacerbation. Despite maximum medical therapy, including nebulized bronchodilators, intravenous corticosteroids, her condition rapidly deteriorated. She became cyanotic, and attempts at endotracheal intubation has failed due to severe airway edema and anatomical difficulties. So the question is, describe your immediate management of this patient, and is there a role of airway ultrasound in the management of this patient? All right, so that will be our case scenario, and I want us to discuss cricothyrotomy, then we'll come to discuss the case scenario. All right, so cricothyrotomy is one of the front of neck access procedures, and the indications of front of neck access includes Fiona, all right, that's my mnemonic. So when you have failed intubation, all right, and you're going to have can't intubate, can't ventilate scenarios, you want to do emergency front of neck access with cricothyrotomy. Patients with inhalational injury, all right, burns and airway obstruction is imminent or has even occurred, and because of the edema, you may not be able to access the airway. When there is foreign body obstruction of the upper airway, either from trauma, foreign bodies, or severe swelling from anaphylaxis or angioedema. Neoplasm involving the airway, like thyroid and laryngeal tumors, all right, and anatomical distortion. Sometimes there was a case like that patient had facial trauma, and obviously, especially the oropharynx, you can't see anything. There is no way you can intubate, so cricothyrotomy becomes indicated. All right, let me see. There's a Okay, good. Somebody I just mentioned that. Okay, we'll go into that. So those are some of the indications. All right, failed intubation, inhalational injury, obstruction, upper airway obstruction, neoplasm involving the airway, especially thyroid and laryngeal tumors. You want to go below that, and anatomical dysfunction. All right, contraindications. You don't want to do a cricothyrotomy if you are able to secure the airway with less invasive means, because cricothyrotomy is invasive. All right, if the airway trauma renders the cricothyroid membrane, inaccessible. All right, you can't do a cricothyrotomy, and some people have concerns with children that are less than 10 years of age, because this group of patients are prone to laryngeal trauma and they have higher incidences of postoperative complications. Although some authors have reported that needle cricothyrotomy can easily be performed in this group of patients, but just note that they have higher incidences of postoperative complications following cricothyrotomy, patients who are 10 years and below. All right, so this is an example of a cricothyroid kit. All right, this is your cannula, large bore cannula, which is connected to a syringe. All right, and you have from needle cricothyrotomy, you may want to do an open cricothyrotomy, and you have your equipment here. So now the procedure we can see on the right side of the of the of the presentation. All right, see the way always locate your cricothyroid membrane, and we're going to look into that with our airway ultrasound. You mark it, or you can do palpation, and you can see the 14 gauge cannula, and you insert it at the angle of 45-degree, corda, all right, towards the field. As you go on, you aspirate with your syringe that we have here before, and once you have correct placement, all right, by aspirating air, you connect to a high pressure oxygen source, or you ventilate manually to confirm placement. But note that this is a bridge method, all right, until you have a definitive airway in situ, and this will actually save a lot of our patients in emergency. So this is needle cricothyrotomy. Then we have the definitive, which is the surgical cricothyrotomy. You want to locate cricothyroid membrane with the use of your ultrasound, and you mark it, all right, and you make a vertical horizontal skin incision over the cricothyroid membrane, and you spread the tissues to expose it, and you enter into the membrane, put your tracheostomy in the tracheal tube, and confirm placement. Then we can also do the Sedenga technique, the percutaneous cricothyrotomy, which is less invasive, but the most important in all of this is identification of the cricothyroid membrane. All right, and this is important because with the guide wire, you have less tissue dissection, tissue exposure, and you use the dilators until you're able to get into the tract and insert your tracheostomy tube. All right, so if we look at our scenario, okay, so this patient had acute exacerbation of asthma, and despite optimized medical management, the patient continued to deteriorate, became cyanotic, and attempts at intubation have failed. All right, so can we have a discussion? So how do you manage this patient? I've mentioned some of them, but let's just discuss. Just unmute and let's discuss. How will you manage this patient, and how is there a role for ultrasound, airway ultrasound, and how will you go about it? Anybody? John Claude, go for it.
Yes, for this patient, he's having upper respiratory tract infection with asthma exacerbation. He has the bronchoconstrictions and the intubation was failed. So first of all, he's having he cannot. There is a can't intubate and he can't ventilate. So you have to approach by doing cricothyroidectomy, but using ultrasound to identify cricothyroid membrane. I think that's how I manage the patient, and then started to ventilate the patient.
Beautiful. Thank you. Thank you. Afosini, I saw your muted. Can you add to it? We can't hear you. Your audio is low.
Is that better?
Yeah, it's better now. Yeah.
Okay. So I wanted to say pretty much the same thing. She is asthmatic. She has upper respiratory tract infection and failed intubation. And so I think I would also go for a front of neck access cricothyroidotomy. Whether I want to do a surgical, I think I would opt for a surgical cricothyroidotomy where the identification of the cricothyroid membrane can either be done by the ultrasound, which is where the role of ultrasound comes in.
Great, great. So this is a sometimes we come across also in theater. I mean in the ICU. All right, either at a failed intubation due to difficult airway, and so having expertise or skill in cricothyrotomy, pretty much, even if it's a needle cricothyrotomy, before you can have a definitive airway, that says the patient get oxygen into the lungs, and that saves the patient. So this is good, and definitely there's a role of ultrasound, airway ultrasound in the management. And as we go on, we're going to look at airway ultrasound, and see how we can identify the cricothyroid membrane. All right, so great answers, great contributions. Let's go.
Please, I want to ask a question.
Yes, please.
I was thinking that before the surgical, because of the time lag, since patient is already cyanotic, is it not better to first of all do the needle cricothyrotomy before you, while ventilating the patient with it, then plan for the surgical?
Yes, I agree with you. That's what we mentioned. So the fastest way to have access, front of neck access, is what you should do. Do your needle cricothyrotomy is faster for you. All right. And if you have expertise for surgical or the percutaneous tracheostomy. But the most important thing is that for you to recognize the CICV scenario, and for you to have the expertise to assess the airway from the front of the neck. All right, that is the most important thing here. All right, thank you, Chidi.
So, also, can we also put?
Yes.
In addition to that, following the assessment, can we also give bronchodilators to help so the patient is already having?
Yes, you will do that. But we're trying to, but the discussion is your airway management of this patient. All the other medical management continues. All right, this patient will also require, ICU admission and ventilatory support, definitely. But we're looking at the airway assessment. Irene Isono, you want to say something?
Good evening, sir. My hand. I want to ask, what if it's ultrasound What about palpating the cricothyroid membrane just below the cricoid cartilage? Can that also suffice?
Yeah, that will suffice if you don't have an ultrasound. Obviously the traditional method is to just palpate for the thyroid cartilage and the cricoid cartilage, and in between them you see the avascular cricothyroid membrane and you assess it. But we're looking at best practices, all right? We're looking at international best practices. That's why I talked about the use of ultrasound to let you know that it increases your safety margin if you have ultrasound and you are skilled at it. And that's why I put it as part of the presentation for us to at least be introduced to airway ultrasound and how to identify some of these structures. All right.
All right, sir.
Okay.
Excuse me. Good evening, Prof. Please, I want to ask in a settings where all these are not available, can one do front of neck access with maybe endotracheal tube?
Yes, you can put any tube there. In fact, those days I remember in medical
Where
school,
cannot.
you can put a pen. All you want is that you want access to the airway, you want oxygen into that patient. All right? Any lumen at all in the tracheal tube, just make sure you have access to that airway, and anything that will deliver oxygen or air to that patient's lung is what you are interested in.
Thank you, Prof.
All right.
Prof, please, I have a question, sir.
Okay, go ahead. We still have some things to discuss, but quickly, go ahead. Go ahead.
Sorry, at the end, sir. At the end, better at the end.
Okay, better. Let's do it at the end. So now let's go to the use of supraglottic airway devices in the ICU. All right. So supraglottic airway devices, all right, or extraglottic, as it may be called, uses, you can use it for blind intubation, all right, passing your tube over a bougie. Bronchoscopy can be done through LMA, and in CICV scenario, your supraglottic airway device can be a lifesaver. Patients who have cardiac arrest and where there are no skilled hands to quickly, pass and the tracheal tube, you can use your LMA or supraglottic airway. In fact, during tracheostomy, you can use it to deliver air, all right, serve as your airway equipment while you're performing your tracheostomy. But know that there are advantages and disadvantages with the use of supraglottic airway device in the ICU. Advantage is that it requires minimal skill, all right, to pass, no muscle relaxant, and no contact with vocal cord, so it's less irritating than your endotracheal tubes. Okay. So disadvantages, don't forget, especially for ICU patients that have gastroparesis or patients who have been fed. All right, it does not offer a perfect seal, so there's no protection against aspiration. All right, and also it may not give you a good airway. There are incidences, case reports of airway obstruction with supraglottic airway devices, your LMA. All right, and sometimes even intubating through the LMA can be problematic, especially for first and second generation LMA because of the crossbar across the aperture, especially for the first generation. All right, so these are some of the advantages we need to be aware of it. All right, so we have different generations. This mostly anesthetic, so we are familiar with this. The first generation, LMA, second generation, and the third generation. Okay, and the first and second generation most of the times are not suitable for intubation, and the third generation, especially the LMA fast track, the intubating LMA, all right, is designed to allow intubation. In fact, some of them, especially the LMC track, can actually have integrated fiber optic capability so that you can have real-time visualization of the focal cords as you go in. The iGel device is unique because they have a pre-shaped non-inflatable cuff, and this allows standard endotracheal tubes. For the LMA fast track intubated LMA, you need to use, they have their own airway, endotracheal tube. But for the iGel, you can use your normal endotracheal tube. And the iGel is also useful for all age groups, from infants to adults. So it's important for us to understand the role of supraglottic airway devices and LMA in the ICU. All right, and actually every ICU should have these airway devices, because they could be lifesavers. Okay. All right, so the intubating LMA, let me just put it there. So this is a fast track LMA, all right, and we have the different types, the first generation, second generation here. So for the use of intubating, one of the very advantages or uses of LMA is to intubate, all right. So what you need to do is that for the fast track, you want to, first of all, predict difficulty, all right, with your LMA passage, all right, and Chris Nixon, all right, in live in the fast lane, just brought rods, so I just had to just reference him here. So some of the difficulty with LMA passage must be, always kept in mind. We have restricted mouth opening. So patients who have restricted mouth opening, all right, it's a predictor of difficult LMA. Obstruction patients with distorted airway, or patients with stiff lungs, all right, or C-spine injury. So these are the patients that may have difficulty with passing your LMA. So more importantly, every ICU should have an intubating LMA, even if it's one or two, like I advocate for video laryngoscope. So you want to insert, your intubating LMA, your fast track, with the aperture facing the laryngeal inlet, and you test ventilate to ensure that you can ventilate, and you feed your endotracheal tube through the inlet or low, all right, and slide the LMA while ensuring the ETT stays in place. You want to confirm correct placement, all right. There are two things: you can either leave the LMA in situ or you remove it completely, all right, to allow the ETT to be in situ, especially after you have confirmed correct placement. And this is it here, all right. This is how to do it. The aperture should be open to the laryngeal inlet, and you feed your endotracheal tube. This handle helps you, all right, almost like the handle of your laryngoscope. So this is very important. This is good in the ICU. And even the iGel also will allow a normal endotracheal tube to be fed through it, and it can be a lifesaver, especially in difficult airway scenarios. Okay, and time is fast spent. I need to talk a little more about ultrasound in airway management. Okay, let me just leave that. These are just some of it. So there are different indications for ultrasound, airway ultrasound. And number one is you want to use it to confirm correct endotracheal placement. In fact, it's been said, so many authors and, authorities have advocated that for every endotracheal intubation, you must always have your, ultrasound to assess your airway. And one of the things you want to assess is you want to be able to, whether it's difficult airway or not, you want to locate the cricothyroid membrane, mark it in case you have difficulty. All right. So airway ultrasound is an added armamentarium, all right, to the intensivist or anesthetist working in ICU. So if you look at the images on the right side of the PowerPoint, you will see how to differentiate between trachea intubation and esophageal intubation. More importantly, you must be able to recognize this is the trachea, all right, and you have the ear mucosa interface here. So with this, you see the hyperechoic here. So there's the tube is inside, all right. It's here, so it's hyperechoic, and this is the trachea. You must be able to recognize the adjacent structures, your skin, your subcutaneous tissue, your plasma and platysmal muscles, and your stenohyoid, omohyoid, and thyrohyoid muscles here. You must be able to recognize your carotid artery on both sides. All right. So you see a single comet tail. All right. It shows that the tube is in the trachea. Albeit, if the tube is in the esophagus, all right, you see the ear mucosa interface here, all right, and showing you a comet tail. So, but this is the esophagus here. You see the presence of the endotracheal tube in the esophagus. So when you have two common tails on airway ultrasound, it's indicative of esophageal intubation. And what you need to do is remove the tube, all right, and repass it. And you can actually do a real-time, examination as you're passing your tube. You could either see the tube pass through the endotracheal tube on ultrasound or not, and you're able to correct quickly and promptly detect it and remove your tube. All right, so another use of ultrasound, airway ultrasound, is to predict difficult airway, difficult laryngoscopy. And what you do is that you use your sublingual ultrasound, all right? And most times you use your curvilinear tube here, all right? So if you're able to visualize the hyoid bone, okay, I don't know if you can see my arrow. This is the hyoid bone here. You're able to visualize the hyoid bone on your sublingual ultrasound. Studies have shown that it correlates more with your Comac and Lahaye grading scale of 1 and 2, which shows a relatively easy laryngoscopy and intubation. So the third one, which is very important, especially concerning front of neck access, is for you to identify. Most of the, you use your linear probe, your high frequency linear probe, and you go on the transverse, all right? Most of the times for confirmation of correct ETT, you place the probe transversely, but for location identification of your cricothyroid membrane, you want to do a longitudinal approach, all right? And this is the image you will likely see, all right? And this is the skin, subcutaneous tissue, your platysmal muscle here, all right? This is your carotid artery here, okay? And what you need to look for, you need to come from the caudal part, and you want to identify a string of beads, all right? That is your tracheal rings, all right? You start, from the suprasternal notch rather, and you go up. The first thing you should be able to recognize, I'm not using the colored ones because you won't see the color. So look at these are the string of beads. These are the tracheal rings. And you go a little careful, and you'll see your cricoid cartilage. All right, cricoid cartilage is hyperechoic, and you go forward a little careful, at about 2 centimeters above that, you'll be able to recognize your thyroid cartilage. So the hypoechoic structure, I don't know if it's moving. So the hypoechoic structure between the tracheal cartilage, the hypoechoic, and the cricoid cartilage is your cricothyroid membrane, and you mark it across the patient. You mark it, and that is where you're able to get your cricothyroid membrane. And it's easier for you to just do a direct either needle cricothyrotomy or surgical cricothyrotomy. And this is also, especially when you have difficult airway, it reduces the risk of injury. All right, some of them could be hemorrhagic and all that. So, it's important. One of the very advantages of airway ultrasound is actually locating and identify the cricothyroid membrane. All right, another thing is to use it. I know that one of our colleagues, this is our part 2 exam dissertation, where you want to use your ultrasound to predict appropriate ETT size. All right, so once you're able to locate your cricoid cartilage, this is the hypoechoic structure, you go a little below it, about 1 to 2 centimeters below it subglottically, and you measure, all right, the distance, all right. So the correct size of your endotracheal tube should be about 0.1 to 1.7 millimeter less than the outer diameter of your endotracheal tube, all right. And this correlates well with CT scan and MRI studies, all right. So these are some of the advantages. Evaluation of the epiglottis, all right, can also be used. Ultrasound can be used for that in case of epiglottitis. Okay, you can also use ultrasound, airway ultrasound to predict post-extubation stridor. All right, sometimes after extubation, a patient goes into respiratory distress from the stridor. All right, these are some of the advantages. So, in conclusion, we've run out of time. Airway management in the critically ill patient is unique, requiring detailed and prompt evaluation and care. It is critical for ICU clinicians to be versed in the different airway management techniques, and the use of ultrasound, airway ultrasound, should be incorporated in every ICU, which increases accuracy and minimizes airway mishaps. Yeah, so we've come to the end. These are the references for your consumption. So, do I have questions? Let me just stop the recording so that we can discuss more.